one of the things that was unique about Dr. Antoine's approach is he's got a couple of these breakthrough technologies that he's now bringing to people that have kind of failed conservative care, and I think it's a good option. But well, let me tell you a little bit about Dr. Jamie Antoine. He's studied at Albany Medical College, and he graduated magna cum laude, which is pretty impressive. Congratulations there. Did surgical internships at the University of Washington, and then also did it with Dr. King, had a great fellowship at the Palo Alto Medical Clinic, who I actually have heard of from multiple people over the years, and had done some stuff with some of the Bay Area sports teams, particularly the Raiders. I don't know if he's in Las Vegas now or what, how that works now that
he retired now. He's not going.
Okay. Now that they've been jettisoned to Sin City. So he headed up the Group Health Kaiser Permanente group for quite a few years, and we're just excited that we have him here in Kirkland at Pro Ortho. So it's been a fun thing getting to work with you over the last couple of years now that you've joined the team there with a good group of docs as your colleagues there. So without further ado, I'll kind of let you hit the ball rolling, and we'll have more people kind of attending as we go. But again, this for anybody that misses any parts of this, if they have to leave early or whatnot, this will be recorded, and we'll be sending out the link again afterwards. So, so thanks so much for joining us.
Great. Okay. Well, thanks for the intro, Ben, and thanks everyone for joining us this afternoon. And hopefully we'll just be able to take 15 or 20 minutes of your time on this nice day and talk about a pretty common and potentially frustrating problem that I've definitely seen in my practice over the last 12 years or so. And honestly, as an orthopedic surgeon, sometimes we haven't had a great answer for this historically. So there's lots of fairly new or novel, more innovative and minimally invasive treatments that are pretty exciting to me as having something to offer folks to maybe get back sooner and with more certainty than some of those previous treatments. So we're going to talk about some of these newer minimally invasive treatment options, particularly focusing today on a couple of different tendons, the patellar tendon and the Achilles tendon. So looking at runner's knee and chronic Achilles tendon type of pain. We'll go through sort of an introduction to some of the anatomy. We have different folks attending the webinar, so we'll go through some basic anatomy, some of the terminology and definitions, which have really evolved over time, and then we'll move into some diagnosis and some imaging, and then finally different treatment options. So starting off, nothing to disclose as far as any financial interests with this talk. So how common of a problem is this? So, most of us probably that have been active over our lives have experienced some pain in different tendon areas. You can see some data there below, which comes from really insurance-based claim data from 2016. So this doesn't pertain to athletes in particular, but if you just look at the general population, you can see that it's a fairly common issue that people will experience, the Achilles tendon being fairly common. And you can see tennis elbow here being fairly common, as well as shoulder problems. But patellar tendon issues are not uncommon, and the gluteal tendon is at the hip, what we often refer to as trochanteric bursitis. Over many years, we sort of understand now maybe due to some tendon issues at the gluteus. So just to review some of that basic anatomy, as I mentioned here, for some of us who may not be familiar, looking over on the left side of the screen, looking at the anatomy of the knee. So we have three bones that are making up the knee joint: the femur here, or thigh bone on the top, the shin bone, which is the tibia, and then the kneecap in the front of the knee, or the patella. And the kneecap's job is really to protect the knee, but from a physics standpoint, what the patella is doing is increasing the amount of force that the quadriceps can exert across the knee. And how does it do it? It does it through this patellar tendon. So the patellar tendon is just the muscle's attachment to the tibia bone that helps the muscle actually extend the knee joint or straighten it. Similarly, on the ankle side of things, the Achilles tendon is the biggest, strongest tendon in our body, and it helps exert force from the calf muscles. to the heel bone, and that's involved with jumping and anytime we push off or take a stride. So looking at some of the definitions, as I mentioned, so we have this term tendinopathy, which we use now to describe tendon pain. And really, it's just a clinical term to describe symptoms related to the tendon. We previously used terms such as tendinitis, and now we tend to favor tendinopathy, and we'll get into why that is in a little bit. But again, a common problem is estimated in that same study, about 28 million people in the United States suffered from tendinopathy. The more active we are, the more we tend to see these symptoms. And so we've seen this in high prevalence in professional athletes, but also in recreational athletes and those who perform repetitive work, particularly upper extremity type of work where we may see issues such as tennis elbow commonly. One study found that this accounts for 30 to 50% of all sports injuries. And in this talk, again, we're going to focus on two in particular. We're going to look at patellar and Achilles tendinopathy. So the way we've approached this has really evolved over the past several decades, and certainly even during my career from the time I started training to now, the way that we think about and treat tendon disease has changed. We've used these terms interchangeably, and so in the literature you may hear tendinitis, and we've all probably heard of tendinitis, but also the terms tendinopathy and tendinosis. And so, as I said, how we think about the problem has changed, and how we think about the cause of the pain has changed, and therefore our treatments have evolved. So if we step back for a second and look at the difference, we'll see that it follows an evolution of the model of how we think about things. So tendinitis was a term that was used previously to describe this and will still be used at times. And so prior to the 1990s, the model of tendon pain was really an inflammation-based model where tendinitis was the term used because itis means inflammation. And so because we thought the main cause was inflammation, the treatment was aimed at decreasing inflammation, essentially treating this with anti-inflammatories. In the 1990s, studies started to be done where people looked at the type of tissue that comes out of samples. For instance, when we do a surgery to remove some of this diseased tissue, it was shown that there's actually very few inflammatory cells in that tissue, and that maybe this is not an inflammatory problem. So in the late 1990s, the terminology started to shift to that of tendinopathy, which simply means disease of the tendon, more so than an inflammation process. So by the 2000s, there's really this shift looking at the difference between tendinitis and more of a degenerative process, or what we call tendinosis. So the term tendinosis is really talking about the breaking down and the deterioration of the actual structure of the tendon. So if we take a look at some of the slides here on the side here, what we're looking at in slide A is the normal appearance of a tendon under the microscope. And so what we'd expect to see is nice, linear, organized fibers here. And what can happen over time is they can break down into this disorganized structure here, where we see these large cells and no real fiber structure. And that corresponds to sort of a scar-like tissue that you would see with the naked eye looking at this. And so further than just thinking about the change with inflammation to more of a degenerative process, work has also been done to show that this is really a continuum working through various stages of degeneration. So if we take a look at some of the specific disease processes, starting with patellar tendinopathy, this is often referred to as jumper's knee, but also known as runner's knee, seen commonly in a running population. Certainly is the most common in jumping type of athletes, where some studies have shown 20 to 30% of athletes who are jumping will experience this at one time or another. Sports such as volleyball or basketball tend to have this the most common, and actually has been shown to be a reason for retirement in professional athletes at a high prevalence. With respect to running, patellar tendinopathy may account for 5% of injuries that we see in runners. And the patellar tendon, as we looked at with the anatomy model, is under a lot of repetitive stress and is in a situation to transmit sometimes as much as 4 times the body weight during running, and this is a reason it's affected so often. So as far as symptoms that we look for that the patient may experience or that we may pick up as clinicians could be pretty straightforward to diagnose. The pain is located typically in the patellar tendon below the kneecap area. Often it will start off being experienced as some morning stiffness, when getting up or after sitting for a long period of time. Things that really load the patellar tendon, such as squatting or lunging or running downhill, will tend to bring out these symptoms more. You may notice that it's tender to the touch, so the examiner may notice that we have some tenderness palpation, or you, the patient, may notice that you have some tenderness there at times. This can progress over stages to become painful with normal activities. Typically, when it starts off, the pain will be noted during the activity or at the start of the activity. Achilles tendinopathy, again, fairly similar, even a higher prevalence in runners. So this can be up to 36% of runners experiencing Achilles tendon-related pain. In a study looking at recreational runners, this was found to affect 9%. Again, similar to that patellar tendon, the Achilles tendon is absorbing a tremendous amount of force with every stride that we take with jumping or with push-off. A lot of these problems can come up, as Ben mentioned in the introduction, after a sudden increase in activity or a change in our training. So we can see this due to training errors, due to ramping up too quickly, or going from sort of a couch to 5K and trying to add new exercises and having some of these relative overuse problems. And the classic with Achilles tendon is seeing a lot of middle-aged males in particular with sort of a weekend warrior picture where there's inactivity during much of the week and then going out and going a little too hard on the weekends. So similar with respect to pain, with startup pain, having some pain first steps in the morning can be pretty common or after prolonged sitting. The Achilles tendon pain can be located in a couple different locations. One can be right at the heel bone where the tendon inserts, and we call this insertional tendinopathy. And the other variety is where it's a little bit above the heel bone insertion, actually known as non-insertional tendinopathy. Over time, you may notice the development of a bump or enlargement in this area. That's less common to see at the patellar tendon. So why does it happen? Okay, so we know certain people will perform these same activities and not have a problem, and others will. We definitely tend to see this come up more as we age, and the reason is probably because the muscle tendon structure itself becomes less flexible as we get older, and there's more force or tension transferred to our tendons. But we can also see this in folks who have chronic medical conditions, see it more in obese patients, but also patients who have diabetes or high cholesterol or other connective tissue diseases are more prone to tendinopathy. And then if we look at factors that are outside of the person themselves, it's about the environment and the training a lot that can cause the problem. So we look at the repetitive demand that is being placed on the body part itself. And as I mentioned, training errors at times with sudden increase in activities. Footwear has also been linked to this, and it's important to have shoes that are not excessively worn out that can absorb some of the shock. The environment of running can also play a role with respect to how many hills are involved or running on certain grades or slopes. And then we also know that it can be seen with certain medications. There's a class of antibiotics known as fluoroquinolones, which have been linked to weakening tendons and causing tendon disease. So looking at different theories over time, we talked about some of the risk factors that can set folks up for this, but what is actually happening at the tendon level? So probably a combination of things are occurring. We think of it essentially as a repetitive overuse type of injury where there's mechanical wear and tear and damage that occurs to our tendons. And every time we work out, we know we're causing a little bit of damage, and we expect our body essentially to repair that and return to normal tendon structure. But what can happen with tendinopathy is essentially that process doesn't occur, and the activity and the damage is outpacing the body's ability to repair it. And so the mechanical wear and tear certainly plays a role. This happens in tendons more than in the muscle itself because the tendons have a very poor blood supply, and so we can have limited ability to repair damage in these locations. Another theory of tendinopathy is that the compression of the tendon near the bone can compromise blood flow and cause some compression failure, such as at the Achilles tendon near our heel. So I mentioned earlier this idea of progressing through different stages of tendinopathy. And this is really work that came out in 2009 and really has helped our understanding of tendon disease is really a continuum of moving through stages. So the first stage is a reactive tendinopathy. If things progress beyond that initial strain or injury, we can move on to tendon disrepair, which is that failure of a healing response that I mentioned, and finally the final stage of degenerative tendinopathy. The arrows there sort of indicate the ideas that we can move through those stages in a forward fashion, but with proper care sometimes can move back to a lesser stage and even to normal tendon, hopefully. So diving a little bit deeper into those stages, as you might think, the reactive tendinopathy is an early appearance where we have an acute overload to that tendon, causing some degree of micro damage, but not gross failure of the tendon overall. Your body's normal response is going to be to respond to that with some repair proteins, but also some pain molecules that are released that our bodies then feel. If we fail to respond appropriately and repair with normal tendon, then we move on to that next stage, which is tendon disrepair, where if you look at the tendon, you start to see the tendon organization start to fail, and the collagen, which is the molecules that are lined up in the tendon, start to become less tightly packed together. And we can actually see this on certain imaging studies, which we'll look at later. Essentially, we start to see scar-type tissue show up in that tendon and the cells that start to make scar tissue, replacing normal tendon with scar. And then the final stage is really to the point where there's mostly scar in that region we're talking about with little collagen fibers there. And this can show up quite well on MRI and ultrasound. So once we have these changes, people have also asked, is this reversible? And so in the early stages, we certainly know that removing the load and the repetition that's causing the problem may allow the tendon to return back to a previous stage. This has been shown also to a varying degree with non-invasive treatments such as physical therapy, in particular eccentric type of training. But many people do believe that with the advanced degenerative changes, similar to what we see here on the right in the Achilles tendon, once we get this thickening and large bumps that can form, that is not going to be reversible without some invasive treatment, either surgical or some of the more minimally invasive modes that I'll discuss later. And there certainly has been some evidence that some of these modalities or treatments have been able to reverse these degenerative changes, which is exciting. So even though we have these abnormalities of the tendon that can be seen well with imaging, the question still comes up of, well, what actually causes the pain? We know that not everyone who has an enlarged tendon or an abnormal appearing tendon on imaging has pain. We also talked about the lack of inflammatory type of cells there. So if it's not inflammation causing the pain, then the question comes up of what is causing the pain. This is not clearly understood, but the more recent thinking is that we know we have abnormal blood vessels that grow into these areas of tendon, and we know there's some nerves that come along with that. So it could be the increased nerves in that area that are responsible for causing the pain. We also know there are some inflammatory markers or molecules that do get released, certainly early on in the process, that may be responsible for some pain there. So to look at how patients show up with this for the therapists in the audience, and also for patients what you may experience, the breakdown of the different phases and being able to recognize where people are often follow some patterns with respect to history. So in the reactive or acute stage of the problem, there's often going to be a recent history of either a strain that a patient felt happen or a recent increase in activity with a fairly new onset of symptoms over the last few weeks. This can be seen in older patients as well as younger patients. When we see patients in the second phase, obviously there's usually more of a story of a chronic problem over the years that may go up and down depending on training or activity. Again, we can see this in both older and younger patients, but at this point we're starting to see on our exam, or people may notice that the tendon involved is even enlarged or thickened, initially thinking it's swelling, but not having that ever go away. And then in the degenerative population, as you may think, that's going to tend to be older patients, probably over 50. But we can see this in some younger athletes, even in their 20s, if they've been at high level activity or high level sports for most of their life, they may really have accelerated this tendinopathy pathway. So we can usually make this diagnosis clinically based on the history and on the physical exam. But when we're starting to think about different treatments, certainly if we're looking at moving on to more invasive treatments, imaging can be helpful as far as looking at the areas of disease and seeing if there is a target for some of those treatments. So the two modalities that we typically will use are MRI and ultrasound. And certainly in the last decade or so, ultrasound has really gained popularity amongst musculoskeletal physicians in being able to look at these tendons. So over here on the right side of the screen, we have some ultrasound projections of an Achilles tendon. And on the right side of the picture here, we have sort of a non-enhanced picture showing the Achilles tendon coming in and inserting onto the heel bone. So the normal tendon structure has these nice linear fibers here coming in and blending into the bone. Whereas on the left side, we can see as the tendon starts to come in, we start to lose some of that signal, and we can actually see little calcifications that are not part of the heel bone, and that actually creates some shadowing behind them. So we're seeing the body laying down some calcium there. And on the bottom is the same imaging, just with the borders of the tendon labeled for everyone, so that's a little more apparent. So more findings that we'll see with imaging. This is a look at Achilles tendinopathy. And one of the nice features with ultrasound is we can actually show some of that new or abnormal blood vessel growth into the area of the diseased and thickened tendon using a power Doppler mode on our ultrasound. And we refer to this as neovascularization, or new blood vessel growth into that area, usually accompanied by nerves that may be responsible for the pain. The middle picture here that we're looking at is a picture of the patellar tendon and patellar tendinopathy. So over here on the right side, we have the shadow of the kneecap bone here, and we're looking at the patellar tendon coming in. And again, we have healthy tendon coming in here, but then all of a sudden we get this lower amount of signal here where the ultrasound signal is not bouncing off those fibers, and that is an area of tendinosis or tendon disease. Here's a similar look on MRI. So we see the patellar tendon coming up to the patella. This is the femur or the thigh bone, and this is the tibia or shin bone. And normal healthy tendon on MRI would have a black signal with this type of MRI. And we can see sort of a grayish signal and some thickening there, which would correspond to similar findings on the ultrasound. So now that we've gone through diagnosis, then we're thinking about how do we treat this problem. So non-operative management has been the mainstay of treatment for many years and is successful in most cases. Our traditional treatments for both of these problems have been relative rest, and what that means is keeping activities below the threshold of pain. So in a runner, this may mean cross-training more or doing more swimming or cycling to minimize the repetitive stress and strain on the affected tendon. We still will start off with a protocol of rest and ice to treat any inflammation process that is there, as well as compression or elevation when appropriate. And this is still appropriate as far as anti-inflammatories and use of NSAIDs, because some of the pain in these situations can certainly be caused by inflammation in the areas around the tendon, and in particular in the tendon sheath. And so we more accurately refer to that as a peritendinitis, meaning inflammation around the tendon, more so than a tendinitis to be accurate. So that's why anti-inflammatories, either injection or oral, may be beneficial. Another part of resting, of course, can involve immobilization or bracing when appropriate, particularly with the Achilles tendon. A walking boot may be helpful for a short period of time, or heel lifts or different orthotics that can take some strain off the tendon. With the knee, there may be a brief period of use of a knee immobilizer if things are really hot and painful, but we again want to be very careful about immobilizing joints and causing weakness or atrophy there, as well as stiffness. Physical therapy is really the mainstay of treatment in most of these cases early on, and again has a positive success rate historically. And then in traditional treatments, often if the non-invasive treatments have failed, the next line when the patients have come back to us after 6 to 8 weeks of this would usually be to offer corticosteroid injections. That may be more applicable to upper extremity. I can say in my practice in the lower extremity, I have stayed away from those because of some of the negative effects and risk of rupture that steroid injections can come with, which we'll get into a little bit later as well. So if we look at non-operative treatment and some of these traditional approaches, as I said, it can be fairly successful, but the literature has actually shown that it may not be as successful or as durable as we think. So in patellar tendinopathy, it's shown success rates of 50 to 70%, and with non-insertional Achilles tendinopathy, around 70% overall. And some of those failures are because of recurrence that patients report within 1 to 2 years of initial success. And so, as I mentioned before, steroids have been used around the body for injections, typically as a next line treatment after failure of physical therapy and oral medications. Recently, I'd say certainly in the last 10 years, this strategy has come under some scrutiny. First of all, if we talk about understanding the disease and thinking it's not due to inflammation as much, it may not make sense to then have an inflammatory or anti-inflammatory strategy to treat this. The studies looking at this in various tendons have also shown that even though it can be effective, we often see that that relief is short term, so usually around 8 weeks or so, and I certainly counsel patients to expect a minimum of 2 months or 8 weeks of relief if steroid does work, but the effects will then wear off compared to other treatments. And it's also been shown, if we look at patients and we follow them out, patients who actually had a steroid injection as part of their treatment may actually end up being worse than patients who did not when you look at how they're doing a year or two later. And the reasons for this are that we know that the steroid injections can change the structure of our tendons. It can weaken the collagen and cause it to become less organized. And of course, in the lower extremity, we have to be really careful as that weakening can lead to rupture of the tendon. So typically, as I mentioned, that's not something I would use around an Achilles tendon or patellar tendon. So we take a look again at the big picture overall with treatment. We can sort of break it down into several categories as far as the way we think about this. So we sort of have a conservative treatment that we always will start with, going through some of those modalities that I mentioned earlier. And then we sort of have this moderate group here, which we'll spend most of the time focusing on, where we have some invasiveness, but typically minimally invasive type of strategies or injection strategies. And then finally, the aggressive treatment, which would be surgery, which would either be open surgery or arthroscopic surgery. So if we take a look at that middle group there with the moderate type of treatment, there is really a great need to be able to add that, because in all honesty, as a surgeon, if we look at the track record of the surgical treatments, they're not particularly great. We haven't really had great answers for that. So certainly when I've seen patients over the years for some of these issues, I've told them that surgery even is not a slam dunk, and we like to do surgeries where the success rate is 90% or greater, and most surgeries for patellar tendon or Achilles tendon surgery don't report that amount of success. So the goal when we do a surgery is to remove the diseased tissue that may be causing pain and to typically abrade that area to stimulate blood flow, to stimulate a healing response. If we look at open surgery for both of these problems, typically we're looking at, certainly for the patella, 6 to 9 months of recovery time before athletes really return to a high level, generally starting around 6 months, but maybe not reaching full performance till 9 months. And the success rate that's reported in medical studies is around 70 to 85%. And this comes along with risks. There's risk of wound healing complications or infection with any incision that we make about the knee, in particular with open surgery. If we look at the Achilles tendon, certainly there's more varied surgeries that are done there depending on the amount of disease. The success rate with those tends to be around the 80–85% rate, but certainly here in this area, there's a higher risk of complications. And typically that's because of the blood flow and risk of wound healing complications around the foot. And so with that, again, we're typically looking at a 6-month recovery time. So certainly some opportunity to have some other interventions that can do better and maybe have less risk. So we'll start off talking about some of the ultrasound guided treatments that we may have. I won't get into PRP injections or some of the other modalities that sort of fall in that moderate range, but we'll focus on some of the ultrasound guided needle therapies today. So percutaneous needle tenotomy is the use of a needle under ultrasound guidance to create several small holes or fenestrations in the diseased area of the tendon. And essentially what this can do is help break up the scar tissue in that area and the abnormal tissue and stimulate the body's own healing response in that area by creating bleeding and signaling some repair molecules. So if you look at the studies that support this, we see pretty comparable, if not better, results compared to surgery when it comes to patellar tendinopathy, with about 70–90% range of good or excellent outcomes in studies. And the Achilles tendon, this is about 75%, which rivals some of the surgical outcomes. The benefit of this, of course, is there's little risk of complication, no risk of wound complication, but certainly a very small risk of infection with a needle puncture, and less recovery time necessary, where now we're talking about a 4 to 6 week recovery before return to sport. Another variation of this that is a little bit newer and more novel is something called the Tenax procedure. And a Tenax procedure is just a form of an ultrasound guided tenotomy that in a similar way can cause some puncturing and fenestration to the tendon. But the benefit of a Tenax procedure is actually the first and only minimally invasive treatment option that removes the diseased tendon. So in a way, we are able to perform a minimally invasive technique that provides the same procedure as an open surgery by removing the diseased tendon, which may be causing the pain, and then also stimulating a healing response. So on the side here, what we have is a picture of the Tenax probe, and this is just an 18 gauge needle essentially, and I have an example here just for size. This is a little bit of the larger probe, but this is an ultrasound needle that vibrates at a frequency, creating ultrasound energy, and that's what actually breaks up the tissue, and it will only break up the diseased tissue and will not harm the normal tissue. So pretty exciting technology that's taken actually from the cataract world and has been used for years to remove cataracts by emulsifying the tissue there and then also removing it. So there's a jet of fluid that also comes out of the device and a suction device, and that will remove the broken down tissue, again, without harming the normal healthy surrounding tissue. So this has been something that's been available since 2013. So there's about 7 years experience in the US with this device and approximately 80,000 cases with an excellent safety track record so far. So here's a little short animation of the Tenax procedure. So basically this is looking at an elbow, but a small puncture incision can be made. And then the Tenax probe is brought in under ultrasound guidance. And this, of course, is all done in a sterile environment. Then the probe can be inserted into the tendon, targeting the diseased tendon area that we can see under ultrasound. And then operating a foot pedal, the needle will start to vibrate, breaking down this tissue while irrigating it with fluid and then sucking the diseased tissue out of the area. So this is a pretty simple procedure that can require from seconds to a few minutes of energy during the procedure after numbing up under local anesthetic. Can be performed in an office setting or an outpatient surgery setting, which is the setting that we use in my practice. So the recovery after this, this can be really thought of as a way to stimulate things or kickstart the healing process in addition to some of the traditional modalities that we'll use. And so this will always be followed by physical therapy after the procedure. resting and performing normal activities only for about the first 3 days. When done in the lower extremity, on the Achilles tendon or on the patellar tendon, we'll usually protect weight bearing for the first week or so. So for the first 3 days or so, minimal weight bearing with use of crutches for the patellar tendon, and then crutches and a walking boot for the Achilles tendon. After the first 3 days or so, a patient can start to put some weight down on that and work on weaning off the crutches and out of the boot by the end of the first week. We're going to want physical therapy to start during that first week after the first 3 days or so. And this will just start with a gentle stretching program, working on making sure we don't lose range of motion, but no aggressive work during the first 3 weeks. And when the pain is controlled and the range of motion restored, then we can move on to some strengthening work in the second 3-week period. And then starting around 4 weeks or so, if appropriate, can start to add some sport-specific training or modalities to work towards return to sport. So again, looking at the 10X procedure, the benefits of this over open surgery can be a rapid return to sport or training in normal activities by 6 to 8 weeks compared to potentially 6+ months with surgery. The other thing that has been shown is often the pain relief can be very quick, even within a week or so, but certainly by 4 to 6 weeks, patients reporting decrease in their pain by up to a half compared to before the procedure. Because it's only performed through a small stab wound incision, there's no stitches required, simply a adhesive bandage and a Steri-Strip over the top with no need for those to be removed later. And unlike some other treatments that have been looked at, like PRP injections, which may be multiple injections, only one treatment is needed with the 10X procedure. And another benefit compared to some of those other modalities is it is covered by insurance compared to PRP injections, which we will sometimes do, but are not covered by insurance. So as mentioned, 10X procedure, a fairly new and novel approach to this. As we're getting 7 years out, essentially from it being approved, we're starting to see some science now being published to back up its efficacy. So the first thing we would want to know, of course, is can it do what it is supposed to do? And looking at some basic science studies in animals, it's been shown that it does in fact remove the diseased tendon, and we can see normal tendon replacing that as soon as 3 weeks in a rabbit model. If we look at how we're doing with clinical outcomes, looking at different areas in the body, this is a little infographic here showing different percentage of positive outcomes in studies looking at different body parts from tennis elbow to jumper's or runner's knee here in the patellar tendon and the Achilles tendon down here, which we'll look at closer. So overall, finding about an 85% success rate of significant pain improvement in various tendons. If we look at the knee itself and patellar tendon, again, these are fairly small studies as there haven't been large long-term studies yet, but looking at an elite group of collegiate athletes, they were able to find 94% able to return to collegiate level athletics after single treatment of jumper's knee. And all of these patients had failed appropriate non-surgical management and have had symptoms for over 3 months. And the other study here is just looking at the fact that it can be used after previous failed surgery with good results, showing that an athlete was able to return to high-level collegiate athletics after 3 months after the treatment. Looking at the Achilles here, again, as we mentioned, looking at the bigger infographic, about 85% of patients with good or excellent results after one treatment. Again, a fairly small sample size published there. And again, showing that the results are durable and that there is not a relapse of symptoms over up to 2 years in patients, and that the procedure seems to be well tolerated with no need for opioid medications during the recovery. So when we look at who may be a candidate for this, similar to the selection really that I would use for patients who are going to undergo open surgery. And so patients who've had pain for at least 3 months typically would be ones we would consider for potential more aggressive treatments. And failing conservative treatments, typically historically before we did surgery, we would look at really 6 months of failed conservative treatment before considering open surgery. We'll look at maybe options of going a little bit earlier now that we have less invasive treatment to offer. And of course, with any procedure we do, an important part is the rehabilitation after. So the patient would need to be willing to undergo and able to undergo the postoperative rehabilitation. So in light of some of the evidence that we have and some of the benefits with the less invasive treatment, sort of proposed that maybe we have a different way of going through the treatment of this patient and a different treatment algorithm. So on the bottom, if we look at sort of the traditional approach, as I mentioned, we'd have therapy going on for often 3 months or so before a patient may see me in my office with symptoms. We may do cortisone injections or various injections, but often we're not going to offer surgery after 3 months. We're going to repeat therapy after that, maybe try some alternative therapies such as prolotherapy to stimulate healing, or even PRP injections, and maybe not come to a decision to have surgery until around this range, knowing that we're going to then have a prolonged recovery of about 6 months or so. With some of the options we now have, knowing that the downtime is minimal and the risk is quite low, one can maybe make the argument that we can cut off this prolonged recovery pathway by intervening a little bit earlier with a less invasive debridement procedure followed by physical therapy, and get folks back to training in athletics or work much sooner than the traditional pathway would have us out over a year. So in summary, some of the take-home points looking at what we've covered is really that our understanding of this problem has evolved over time from one of an inflammation type of process to really understanding it as a chronic disease where the tendon has changed and been replaced by scar-type tissue, and that's led to a different approach. Still, I think it's important to understand, although we have these techniques, that the traditional non-invasive approach works in the majority of time, and that's certainly our first go-to. But I think what many of us maybe don't know is there's a relapse in a fairly high percentage of patients, and we may not see the patient back. Certainly I know that I may not see every patient back that has a treatment failure. They may simply not seek further treatment or go somewhere else. So I think we have some pretty exciting novel treatments that are potentially out there that may really change our treatment algorithm and allow us to intervene with very low risk and a fairly good chance of success early on to sort of take people out of this cycle of pain and disability somewhat sooner. All right, thank you. And with that, I'll throw it back to Ben.